Hello, ladies and gentlemen. Welcome to Cardiology. I am Dr. Nik Nikam. I have been a cardiologist at the Texas Medical Center for more than 30 years. And today we are going to learn something about coronary angiography. Here we have coronary anatomy. There are two main coronary arteries that supply the heart, namely the left coronary artery system and the right coronary artery system. The left coronary artery arises from the left cusp, and we have the left main coronary artery which divides into the left anterior descending branch and the circumflex which wraps around the left atrioventricular groove and supplies the lateral and the posterior walls. The left anterior descending artery gives rise to the septal branches which are perpendicular to the main left anterior descending trunk, and it also gives rise to 1 to 3 diagonal branches that supply the anterior wall. The septal branches supply the left ventricular septum. The circumflex, as it wraps around the left atrioventricular groove, gives rise to 2 or maybe 3 marginal branches that supply the lateral wall and the posterior wall. On the right side, we have the right coronary artery which arises from the anterior cusp, and it traverses through the right atrioventricular groove. It gives rise to the sinus node branch, and it also gives rise to acute marginal branches which supply the right ventricular wall. The right coronary artery wraps around the posterior aspect of the atrioventricular groove and gives rise to a major branch known as the posterior descending artery, which supplies the inferior wall of the left ventricle. And we also see some collaterals going from the right coronary artery to the left anterior descending branch and the circumflex branches, and we'll talk about those in a minute. Here is a different way of looking at coronary angiograms. As you can see, again we have the left main coronary artery, then here we have the circumflex trunk which gives rise to the marginal branches, and the left atrial branch is here. The left anterior descending artery gives rise to the perpendicular septal branches and the diagonal branch. And this is all looking from different angles. This is looking from the left side of the chest. As you can see, the left anterior descending artery comes to the front of the heart, and the circumflex wraps around the back of the heart. Similarly, we have the right coronary artery in right oravo projection, left anterior oblique projection, and left lateral projections. The cardiac catheterization is done using catheters. As you can see, we have the left Jetkins catheter which is positioned in the main aorta, and the tip is seated in the left main coronary artery. And through this catheter, we inject contrast material which lights up the coronary artery one at a time, and then we run a cine angiogram to record the findings. As you know, coronary angiography is the gold standard for determining the degree of stenosis, the location of the stenosis, the status of the arteries beyond the location, and the collateral circulations, etc., etc. Here is an actual coronary angiogram, and recalling from our coronary anatomy, we have the left main coronary artery here, and there is the left anterior descending branch which travels through the interventricular groove to the apex of the left ventricle, and we can see the septal branches which are perpendicular to the left anterior descending main trunk. That is how we identify the left anterior descending artery in circumstances when the anatomy is totally distorted and is difficult to appreciate. The left anterior descending also gives rise to the diagonal branches. They could be varying anywhere from 1 to 3 branches. Back side of the heart, we have the circumflexor trunk which is traveling here, and it gives rise to, here we see a large marginal branch which is supplying the lateral wall of the left ventricle, and the terminal branches supply the posterior wall of the left ventricle. Here is a different way of looking at the same left coronary artery. We have the left main coronary artery, the circumflex branch, the obtuse marginal branch, Again, we have the left anterior descending branch, which is identified by its septal perforators and the diagonal branch. Now here we have both the right and the left coronary artery. Here we have the left coronary artery. The significant finding in this slide is almost to 75% stenosis of the left anterior descending branch. On this side, we have the right coronary artery, which gives rise to the sinus node branch, and it gives rise to acute marginal branches, which are really tiny here. And then it traverses to the back of the heart and gives rise to the posterior descending branch, or the PDA, as it is commonly called. Here again we have an example of a right coronary angiogram with critical stenosis in the mid portion of the right coronary artery, right after one of the acute marginal branches that supply the right ventricle. The total occlusion of a coronary artery can lead to an acute inferior wall myocardial infarction, and this type of lesion would certainly warrant coronary intervention such as angioplasty and placement of a coronary artery stent. Here is an example of another left coronary system. We have the left main coronary artery. Here, instead of two branches, we have a third branch which is arising almost from the left main coronary artery. So we have the left anterior descending branch, which is characterized by its perpendicular septal perforators, the diagonal branch. Then we have the circumflex trunk with very tiny marginal branches, but this is now called as the ramus intermedius. So that's one of the variations of a coronary anatomy that we see during angiography. Here is an example of another left coronary angiogram where we see a critical stenosis in the proximal portion of the left anterior descending artery. An acute occlusion of a left anterior descending artery would involve the septum, it could involve the anterior wall, and also the apex of the left ventricle. So generally an acute STEMI can result in the anteroseptal region if we have an occlusion of the left anterior descending branch. As you can see, there is a critical stenosis here in the left anterior descending branch, and these patients may present with non-STEMI clinical presentation because there is still some degree of perfusion visible in the left anterior distribution region. Similarly, there is a mild narrowing in the circumflex trunk in this artery. Okay, here's an example of a left main coronary artery, the circumflex trunk and the left anterior descending branch. And interestingly, if you look at here, it looks like a tubular structure, very straight border, and this represents a stent in the left anterior descending branch. We are looking at more coronary angiograms. As we can see here, we have another coronary angiogram looking at it from a different angle, probably LAO, and we see a critical stenosis in the left anterior descending branch. This is again a left coronary angiogram. The circumflex branch looks okay, the marginal is looking all right, but we got serious problem here in the left anterior descending branch. There is thrombus, as you can see, there is filling defect, and there is total occlusion beyond that. This will certainly result as a STEMI involving the anteroseptal or maybe anterolateral region. This is a very serious situation. Unless we intervene, there could be extensive myocardial damage which can lead to cardiogenic shock. And these are the patients who would benefit through coronary intervention. Again, because there is so much thrombus present here, the thrombus may have to be extracted before opening up this artery and placing a coronary stent. Here is another example of a left main coronary artery. This is looking from a different angle, and this is a left anterior descending branch. As I said before, sometimes it may be difficult to identify various branches. The most important finding to identify left anterior descending branch would be the perpendicular septal branches. As you can see, there is a very tight stenosis of greater than 90% in the proximal left anterior descending artery before the first septal branch. So this is an important lesion because this can lead to extensive anteroseptal myocardial infarction, and since there is still perfusion, this is the time to do coronary intervention and open up the artery. So hopefully we can prevent any major further cardiac event such as acute myocardial infarction. We talked about stent, and the way the stent is placed in the coronary artery is depicted in this picture. When there is a critical blockage in a coronary artery, even before we put a stent catheter, we pass a guide wire through this lesion, and over this guide wire a plain balloon is passed and the plaque is compressed. After the plaque is compressed, then this stent mounted balloon is advanced and placed in the region of the plaque, and when the balloon is expanded, the plaque is compressed, the walls are plastered to the arterial lining. As a result, there is a widening of the lumen with good blood flow, and also the stent will prevent any plaque from rupturing into the arterial lumen. And this is how you have a guide catheter that is placed in the ostium of the coronary artery, and from there the balloon catheter or the stent catheter is placed at the site of the plaque buildup, and then the stent is expanded and left in place, and the stent stays there permanently. There is no way to take this stent out. Let's look at some more angiograms. Here is a coronary artery which is in deep trouble. This is a right coronary artery. There is a critical stenosis here, and there is critical stenosis, and beyond that we hardly see any visualization of the right coronary artery. And incidentally, you can also see a guide wire here which has been advanced through angiographic guidance into the distal segments of the right coronary artery, and there is placement of what looks like possibly a stent which is marked by these two dots, one dot here and another dot here. Once the stent is expanded, now we have complete revascularization of the right coronary artery. And another interesting point that we can see is the stent extends all the way from here to the distal segment of the right coronary artery. This is what we call in cardiology as a straight metal jacket, because the entire right coronary artery is filled with probably more than 2 coronary stents. Here is another example of a total occlusion of the right coronary artery, which probably results in a STEMI, and the STEMI usually involves the inferior wall, and sometimes it can also involve the right ventricle because this is so proximal. That's where you really have to think about if you develop shock, whether you are dealing with a patient with right infarction, right ventricular infarction along with inferior wall infarction. And obviously this vessel has been opened up, and here you can see the outline of a stent, and there is re-establishment of the circulation beyond the stent region. All right, now let's look at it. This was probably a baseline angiogram in this patient, and now look at this. We have a total occlusion of the left anterior descending branch, and they are trying to advance the guide wire here, and because the lesion is so proximal, it may be involving the diagonal branch. So we have 2 guide wires in this, and after opening of the plaque and placement of stent, here is the re-establishment of the circulation in the left anterior descending branch, and here is your circumflex branch along with the marginal branch. Now here's an example of a right coronary artery, and as you can see, there is almost 99% stenosis of the right coronary artery in its distal 1/3, and here you can see the 2 dots representing the placement of a stent before it is expanded, and after the expansion you can see the lumen of the right coronary artery has been restored. There is good blood flow beyond previous stenosis, and when we see this kind of a flow, this is called as TIMI-3 flow, which is normal blood flow through the coronary artery. Here is an example of another patient who maybe during a procedure develops acute coronary thrombosis. As you can see, there is critical stenosis in the diagonal branch, and this is the left anterior branch because we can see these septal perforators, and here is probably an old stent, I would say, and now we have acute stent thrombosis. That's an inference. In these situations, again, you put a guide wire through this one. You open up with a balloon, and later on, another stent is placed. And if there is a stent already, we can try to expand the stent. And in most cases, they may end up getting a stent on top of a stent. And here is a stent extending from here to almost this region, and so there is re-establishment of the circulation here. There is a critical stenosis in the diagonal branch, but since this diagonal branch is relatively small, there is nothing that needs to be done because there may be some evidence of a mild myocardial damage, but that should not in any way alter the long-term prognosis of a patient as long as we have the left anterior descending artery which is widely open. This is a very serious situation. Here we have the left main coronary artery, and here is a stent, and there is practically no blood flow through the stent. There might have been acute thrombosis of the stent region itself. So this is and even circumflex flow is very nominal. This is a real serious situation. This is one of the worst possible scenarios you can see in coronary angiography, where the left main, the circumflex trunk, and the left anterior descending branch, all of them are involved with a plaque that makes it almost very difficult to manage. I mean, it can be managed. One way to do this would be to take this patient for coronary artery bypass surgery and perform complete revascularization. If this patient had this type of angiogram, along with critical stenosis of the right coronary artery, then definitely the treatment of choice would be coronary bypass surgery. And it is especially so in high-risk patients, such as those who have hypertension, diabetes, and reduced left ventricular function. Here's another example of a coronary angiogram. Now we see a critical stenosis in the left main trunk itself. In most cases, this left main coronary artery can also be treated with placement of a coronary stent with reasonably good results and long-term prognosis. Let's talk about coronary artery bypass surgery and some coronary angiograms to look at how the bypass grafts look. And here's an example of a left anterior descending artery which is connected to the left internal thoracic artery, which is commonly known as LEMA, which is used. LEMA is used because LEMA has a much better patency rate compared to saphenous venous grafts, which are used for bypassing other regions of the coronary arterial system. And here is a depiction of a multi-vessel bypass surgery. Here we have an artery taken from a right arm, the right radial artery, which is connected to the circumflex marginal branch. And here we have the LEMA, which is connected to the left anterior descending branch. Then again, here we have the right internal thoracic artery, which is connected to the posterior descending branch and the posterolateral branch. And in most cases, you may see saphenous vein grafts connected to the circumflex trunk and to the distal right coronary artery. And here's an example of a radial artery being taken for doing the bypass graft. Here's an example of a patient with a coronary artery bypass surgery, and the way we say that this patient had the coronary artery bypass surgery is by looking at these sternal wires. That's an indication this patient had open heart surgery. And here's a vein graft which is supplying the distal part of the right coronary artery. Here's an example of a lima, which is a left internal mammary artery, which is connected to the left anterior descending branch, and there is also a jump graft that is connected to the lima and to the right coronary artery in the same patient. Because, as you can see, the sternal wires indicate this patient already had a bypass surgery in the past. So this is an indication that the bypass grafts are open. Here we are injecting contrast in left internal mammary artery, which is connected to the left anterior descending branch, and it lights up, and as you can see, there is total occlusion of the left anterior descending branch in the proximal segment. Now let's shift gears and look at ventricular function, which is done by injecting contrast into the left ventricular cavity, and this is recorded on a cine angiogram, and using this we can measure the left ventricular volume during systole and diastole, and by that we can measure the left ventricular ejection fraction. And here are the aortic cusps, and this is the main aorta, and this is the left ventricular cavity filled with contrast material, and this is during diastole when the ventricle is completely filled with blood, and this is during ventricular systole where the ventricle has contracted, and using these two frames the computer calculates the left ventricular ejection fraction. Let's talk about aortic dissection. Here is an MRI showing a dissection of the descending thoracic aorta. As you can see, there's a double lumen here, and this is a pretty serious condition. Unless it is treated surgically, there is a very, very high mortality in these patients. Well, ladies and gentlemen, that is in a nutshell introduction to cardiac catheterization and coronary angiography, left ventriculogram and aortograms. I hope this has been helpful to you, and please do subscribe to our YouTube channel so we can bring you similar educational programs for your enrichment. I am Dr. Nik Nikam, and thank you so much for watching.